So that's a recognizable area there just before the duodenal changes to jejunum, where it makes this right angle bend. So we have superior mesenteric artery and vein seen in this just inferior aspect of the stomach, where it comes behind the stomach but in front of the small intestinal duodenum. Inferior mesenteric artery, no change, all right? It's the left colic branch and superior rectal branch. No change to those or to any of the branches of the internal iliac, the middle rectal or inferior rectal. Okay, those are the same. So again, without being able to see through the mentum here, splenic, forming short gastric, and left gastromental. Left gastric the same, common hepatic giving off the gastroduodenal, which gives off the right gastromental, and then right gastric joining with the left gastric. Okay? And here's the superior mesenteric artery and vein going behind the stomach. The stomach has been lifted up so we can see that, but coming anterior. So that's a marker that will help you also distinguish the change from duodenum to jejunum, the first and second part of the small intestine. So superior mesenteric, supplying the 21 feet of the small intestine, all right? Duodenum is this region here, so pretty easy to distinguish that from the other part. When we talk about the small intestine, there are changes internally, histologically, but the only way to tell the difference externally is if we have this blood supply. You'll notice how these arcades form along the length of the small intestine. I don't know why, except for increased absorption occurs. The jejunum has just a single set of arcades. As soon as we get to a multiple set, we're at the last part of the small intestine, which is the ileum. Okay? So I'll remind you of that when we talk about the parts of the small intestine. So by multiple arcades, I'm talking about these structures here, compared to here where we have just a single arching form. All right, then the inferior mesenteric giving off left colic and superior rectal. And then we have the internal iliac giving off middle rectal, pudendal, and inferior rectal. So those are all the same as we learned previously. And our veins are the same as far as the portal system is concerned. So we have the veins for the stomach structure. So there's the superior mesenteric vein joining with splenic. We had this diagram before to form the hepatic portal, which receives our gastric, and then the inferior mesenteric drains into splenic. Okay? If we talk about the portal system, this unit will make more sense, where we have the two capillary beds again. First capillary bed in the intestines and second capillary bed in the liver. So that will make more sense when we talk about the function of the liver. Okay, kind of laying down housekeeping stuff here, organization. Any questions on the blood supply? Okay, or drainage? May I erase the board? All right. The last opportunity for some extensive histology. We have some excellent histology models, not just microscope activity. So, the G pad up there stands for General Plan Alimentary is an older term for digestive. General plan of the alimentary tract. So this is an arrangement of the lining of the digestive tract, associated connective tissue and smooth muscle, as we move through the wall, and then finally the visceral peritoneum on the outside, okay? Which we can kind of tug and pull and get to fit everything from the mouth down to the anal canal. So as we go through this, as we get to each of the different regions of the digestive tract, along with talking about the parts of the mouth or the parts of the stomach, we'll look at the general plan of the alimentary tract, okay? But I want to just kind of look over some general characteristics. And let's see. This should remind you of our intestinal wall model that had the lymphatic follicles on it. I'll bring that out as well. That might show the general plan a little bit better. So we're going to start with the lining of the digestive tract, and that forms the mucosal layer because it's a mucous epithelium. Anything, the mucous membrane is anything that's not a serous membrane or the skin or synovial, all right? So, let's use the term here. So the mucosal layer is formed of epithelium, like any mucous membrane, and connective tissue. We only have two different epithelia, all right? We start with one, and we end with one, and the other one's in between. So our starting epithelium is non-cornified stratified squamous epithelia. You find that in the mouth, and about half of the esophagus, well actually all the esophagus. And then we don't see it again until the last couple of inches of the digestive tract, which is the anal canal. Okay? Now remember, non-cornified stratified squamous is for abrasion. And so before we chewed our food and digested it, if you've ever, chewed corn chips before, swallowed corn chips before chewing them very well, you can imagine that that would have an abrasive effect on the lining of your gut. And if you've ever been constipated, all right, you can scrape those fibers along the anal canal as well. So those two regions have non-cornified stratified squamous to protect against abrasion. And then we have loose irregular connective tissue, which is our standard connective tissue that we associate with every epithelia. Okay? Now, in addition to that, in parts of the digestive tract, we have smooth muscle. Okay? See where I want to put the red here. It starts, we have this smooth muscle whenever we have smooth muscle in the wall of our digestive tract. So I'm going to put these in parentheses because it's not present for the entire. Now this is known as the muscularis mucosa, or the muscle of the mucosa. So looking at our model of the small intestine, here would be the epithelium, all right, which I need to add. I didn't put up the second one. So in between the two regions of non-cornified stratified squamous, we have simple columnar. So that would be between the esophagus and the anal canal, all right? Is this going to have cilia or microvilli? Microvilli for surface area for enzyme secretion, and absorption of our digested foods. So in the small intestine, we have simple columnar epithelia. That's what this is indicating here. The gray material would be the loose irregular connective tissue. And this pink line right here is the muscularis mucosa. Okay, it's about 2 layers of smooth muscle, and it helps to throw the epithelial lining into folds so that it can expand as needed. Remember the rugae of the urinary bladder? Similar to that. Okay? So that all belongs to the mucosa. And in your lecture notes, I have this broken down and written a little bit, giving examples of where these tissues are. All right. Now, underneath the mucosa, we have the submucosa. And this is what attaches the mucosal surface to our muscle layer. Okay? So this would be equivalent to our, if you think of the skin, we had the epithelium of the skin, and then we had our loose irregular connective tissue, which was the papillary layer of the dermis. That would be equivalent to what we have here. And then the submucosa would be equivalent to our reticular layer. Anybody remember what kind of epithelium the reticular layer is formed of the skin? I'm sorry, I could ask you to go way back to remember. No, it's connective tissue. So that's what we're going to find here, neat to the muscularis mucosa. So we go from loose irregular to dense irregular, all right? So that's the submucosa. And that's connective tissue. And that is dense. Now we do have some specializations, all right? So we have some mucosal glands to protect the esophagus from the hydrochloric acid of the stomach, or to protect the duodenum from the hydrochloric acid of the stomach. We've already talked about the Peyer's patches in the ileum, the lymphatic follicles. So there are regions where we have some specific components in addition to just the epithelia, all right? Okay, the next layer, we have 4. The next layer is called the muscularis. And some people just leave it at that, but to differentiate it from our muscularis mucosa, I want you to include muscularis externa. Okay, and this is the layer of muscle that provides the movement of the food through the digestive tract, peristalsis. Now, when we talk about the mouth, of course, we don't have any smooth muscle there. It's the masseter and the muscles of our mouth. So we start out with skeletal, all right? We end with skeletal with our external anal sphincter, but everything else in between is going to be smooth muscle, okay? So the muscularis externa typically is smooth muscle. And as such, typically has 2 layers. An inner circular layer, meaning the muscle cells are oriented like a blood vessel around the diameter of the lumen. And that's going to provide constriction, all right? And then an outer longitudinal layer. And that's going to run the length of the gut, the digestive tract, and that provides shortening. Not shortening as in fat, but shortening of the digestive tract. So those 2 together work for peristalsis. If you've ever lost the string of a sweatshirt or a pair of sweatpants, okay, you can get it back in there by a large safety pin. Hopefully you closed it first. Attach it to the string, push it into the opening of the waistband, and then the way you move it along is you grab it in front, push it up. That would be the longitudinal shortening. Grab it behind the safety pin. That would be the circular muscle. And then you pull it out behind it. Then you push it up again, and you keep doing that, and that's peristalsis. Okay, so that's how we use our circular and longitudinal layers. Now we do have some specializations. So in the stomach, we're going to have a third layer. And in the large intestine, we kind of modify that outer layer. So inner circular layer, outer longitudinal layer. Okay? Inner circular is the closest to the lumen. And then that's why it's called inner. And then we have the outer longitudinal. So here it looks the muscle cells are cut in cross section. But if I turn it around, they're cut in longitudinal section. Okay? And that's because in the bottle, we're either cutting it in cross section or longitudinal. So it just kind of varies the pattern. And you can see that here. All right? So if we cut the digestive tract parallel to the whole gut, we're going to be seeing the inner circular cells cut in cross section and the outer longitudinal cut the length of the muscle cell versus cutting in a cross section, and the orientation of the fibers change. One left, and that we've already talked about. It's given a different name, but we've already talked about it. And this is the serosa. When we're talking about the stomach and the small intestine and the colon that are found within the peritoneal cavity, the serosa is the same as our visceral peritoneum. Okay? Of course, we don't have a peritoneum in the esophagus, in the thoracic cavity, or down in the pelvic cavity where we have the lower part of the rectum. But for most of the digestive tract, the serosa is going to be the same as our visceral peritoneum. And I've already given you the epithelium of that. Loose or regular connective tissues, so we attach it to the muscularis externa. And then this is a serous membrane, so the epithelium is going to be a simple squamous epithelium. All right, so we have a lining epithelium and we have a covering epithelium. So now as we go through each of the regions of the digestive tract, we'll discuss what each of these components are represented by. So we have four again: mucosa, submucosa, muscularis externa, and the serosa. Okay? And we'll see variations of those as we move through. This happens to be from the stomach. A little bit easier to see probably from the side. Here would be the epithelium, which is now simple columnar. All right? A little difficult to see the loose irregular connective tissue in the stomach because there's not very much of it. Here's our muscularis mucosa, connective tissue of the submucosa. Then we have the muscularis externa. The stomach happens to have a third layer because it churns. So to help it twist, we have an innermost oblique, inner circular, and outer longitudinal. And then right at the bottom, we have our visceral peritoneum forming the serosa. Okay? All right. So all of that has been just to set the stage. Okay? So now let's start with the beginning, the origin of our digestive tract. So when we have an origin, everything in relationship to that we can talk about being proximal or distal. Okay? So the mouth is the origin of our digestive tract. So the esophagus would be distal to the mouth, but the esophagus would be proximal to the stomach. If we talk about food moving through that region. So may I erase what's on the board? You guys have that down? So last time I drew the mouth, we were looking more at the respiratory tract. Okay, so I didn't do a whole lot with it. I'm not going to try to do a front-on view. I'll leave that up on the screen. Do a little bit of a nose. We have our same bony structures. Keep it closer together than that, so use the artistic license here. Okay. So, come back to this image. See how close I am to realize. Oh, first question. Okay. Guys got used to this without it for a little bit. Which of the following organs of the digestive tube is associated with the function of mechanical digestion? I mentioned it like 3 times at the very beginning of lecture. How many answers? 2. The only function of the esophagus is to connect the mouth and the stomach. It doesn't really do anything else. Okay, so mechanical digestion, if you recall, is breaking things down into smaller pieces. All right? So almost everybody thinks of the teeth for doing that, but how many of you actually chew your food for 6 or 7 minutes? Not very many people. And yet it still gets digested. All right? So most of that gets done in the stomach, where we have the twisting. Remember I mentioned the 3rd layer? The churning of the stomach, twisting back and forth. We do have enzymes that work on food in the stomach, but its primary role is mechanical digestion. Okay, we actually have enzymes in the mouth too, but we normally don't have food in there long enough for the enzymes to do much activity. The esophagus is a connecting organ. Small intestine for digestion and absorption of food particles. Large intestine, primarily absorption of water and some vitamins and vitamin K from the and some fat-soluble vitamins. Okay? All right, so here's a diagram of the mouth, kind of similar to what I drew. Bony structures. Hard palate again. Formed by the maxillary bone and palating bone. All right. Soft palate. Where we have no bone. And if we look at this structure from an anterior view, which is the one I just changed back. So up here would be soft palate, where we don't have the bones. And this structure hanging down is called the uvula. Okay? Then this weird looking bone down here would be the mandible. And both our maxillary and our mandible bones have teeth. All right, so we get to talk about the teeth before we leave this region. Now, we have multiple sphincters. Sphincters, as you recall from the urethral sphincter, are circular arrangements of muscle that can contract and relax. Okay? First time we saw those really was in Bio 430, forming the pupil. Okay? So the very first sphincter that we have is actually this one right here. What muscle is that? Forms the lips as well as it forms a ring that's not really specifically part of the actual lips.
Labia?
Orbicularis? Which one? We have one up here too.
The oris?
So this one is the oris, okay? So this ring-like muscle here of the lips as well as above and below. Is the orbicularis oris muscle. Does that open or close the mouth? Sphincter closes. You have any kids that refuse to eat, they don't go. They go. Okay? So that is what closes the lips. And I don't know if you remember the muscle levator labii, all right, and depressor labii. I describe them as the fish mouth muscles. So they do this. One lifts up and one lifts down, and that's how we open the lips, okay? So this is going to close the mouth, not by moving the mandible, but in the sense the lip, right? And then the other two muscles are levator labii is our word for lip. Levator labii superioris, so lifts the lip, the upper lip, and lowers the lower lip. Depressor labii inferioris. So there's other muscles that smile and frown and all of that, but we're just concerned about getting some food in their mouth, okay? All right, so what muscles, well, before we leave that, on the outside, what muscles, and so as we look at the mouth, these muscles would be contributing to what of the four layers that we just talked about? Mucosa, submucosa, muscularis externa, serosa. Muscularis externa. Okay? So I'll come back to that and I'll write it out as a list for you. So that opens the mouth. The mouth itself is the oral cavity. And what kind of epithelium lines the mouth? Non-cornified, stratified squamous. Okay. Now, we also have a vestibule that we associate with the mouth. The vestibule for the respiratory system was the space of your nostril, which was still a non-cornified, stratified squamous. All right? That was the answer to one of the lab exam questions. But we have a vestibule that happens to be between the skin and muscle and the gum of your teeth. So if you take your tongue, let's say you've got some food stuck in your teeth or something, you rub it around, that's the vestibule. Okay? So let's see if I can go back to the previous. So between the cheek and lips and the gum line is the vestibule. The oral cavity would be within the teeth, okay, where the tongue is. Anybody remember the muscle that we use to keep food from building up in the vestibule? Yeah, does that? Compresses the cheeks. Not to keep you from puffing out while you're blowing a wind instrument, but to keep food within the middle of your oral cavity and not in your vestibule. What's that muscle? Buccinator? Yes, buccinator or buccinator, okay? So over here, I'll write some of those additional. Is that a chewing muscle? No. It does not move the mandible, okay? So it's really just keeping the food outside the vestibule, okay? Muscle of facial expression. So our facial nerve. All right, what are some chewing muscles then? Muscles that pull the jaw up. Masseter. That's the one that if you clench your jaw, put your fingers right there, you get shorter and fatter. Okay, put your hand up here and clench your jaw. What's that muscle? What's that region of the skull? temporal bone. So our temporalis. Okay, coming off of the sphenoid bone, you have to cut away the mandible to visualize it. One of these muscles will pull the jaw forward. Both of them swing the jaw from side to side. First letter is silent. Pterygoids, yeah. So we have medial and lateral pterygoids. All right, these are all chewing. And what's the nerve that innervates our chewing muscles? Nope. Nope. It's usually, most of it is a sensory, but a small component of the third part is for chewing muscles. There you go. I hope somebody caught on to that clue, the third part. So this is trigeminal. The third part of the fifth cranial nerve. All right, so we pretty much created the muscularis externa of the mouth, except for the floor of the mouth. This is a little more tricky. Anybody remember the muscle that forms the floor of the mouth? It will also function to lower the mandible. So if you put your thumb here, you push up and you try to force your mandible down, it helps the gnat. Forms the floor, it fills in all the space between the angle of your jaw. Starts with an M. It also attaches to the hyoid. Mylohyoid. Okay? So that's the floor of the mouth. And that's also innervated by facial. Okay. So all of those muscles would be the equivalent of our muscularis externa. Okay? Because they form the structure of the tube that is the mouth. All right, running out of room here. I'm going to erase the uvula. Now we have the tongue. So what is this fan-shaped muscle that functions to push the, functions to push the tongue out, sticking your tongue out? Comes from the bend of the mandible. Anybody remember the word for bend? The queen comes to visit and you slightly bend your knees. Genu, yeah, genuflect. All right, so that fan-shaped muscle is the genial glossus muscle. Now, we have another muscle that functions to pull the tongue up and towards the back. So when you swallow, so here's the genial glossus, that fan-shaped one, that's the largest one. Anybody ever eaten tongue? Is it good?
Yes.
It's not tough and chewy?
No, it's not.
Cow tongue, I assume? Not people tongue. All right, so this muscle right here has been cut, but it's actually coming down from the temporal bone from the styloid process, and the fibers insert into genial glossus. So its origin is up and behind the tongue. So it's going to pull the tongue up and towards the back, and that pushes food into your throat, your pharynx. All right? So what do we think we call a muscle that comes from the styloid process and inserts into the meat of the tongue? Styloglossus. Who knew? Okay, so that's an important one for swallowing. It pulls the tongue in the opposite direction in genial glossus. And then this muscle on the side that looks a bit like a rudder, okay, stabilizes the tongue and pulls the base of it back down. It's coming from the hyoid bone. So we call it the hyoglossus. remember the nerve for the tongue? Also has glossus in its name. No? Hypo. Yeah, that one goes to the salivary gland. Hypoglossal nerve. Cranial nerve 12. You didn't know you were taking bio 430 all over again tonight. Okay. I don't know if I have any more room up there, but we have a few more things to talk about, and that's sensory. Okay? So, I'm going to put that in green. For some reason, I usually draw sensory in green. So, you are chewing away, and you bite the inside of your mouth. Maybe you had some dental work and it was numb and you didn't realize that for a while. So, sensory. So you burn your tongue, the inside of your mouth because your drink is too hot. What is the cranial nerve for sensory to the mouth? Trigeminal. So that's considered to be soma. We have skeletal muscle. So sensory for the mouth is going to be trigeminal. Again, the third branch. And then we have the tongue itself. All right? Sensory to the tongue is trigeminal as well, except for the back part of the tongue, and that would be glossopharyngeal. Okay? But we also have taste. All right? We have 3 cranial nerves for taste. So, facial. And glossopharyngeal. We'll talk about taste buds in just a moment. And that's for the tongue. And then vagus, essentially for the rest of the mouth, like the sides of the wall, the back of the pharynx. We have some taste receptors there. Vagus doesn't do the tongue, but it does essentially the wall of the mouth. Okay? All right. A couple more structures. And I know we have a break coming up here, so we'll do taste buds and stuff when we get back. May I erase what's on the board? You guys have all that down?